Good evening. Good evening, everyone. I welcome you all for today's webinar on recent updates in the management of lung cancer. And for this, I would like to invite Dr. N. Aditya Murli, who is consultant medical and hemato-oncologist, Esther CMI Hospital, Bangalore, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you to all our kind sponsors for organizing this meeting, and thanks Horizon for being so gracious and efficient as ever. Today, over the next couple of hours, we would be discussing some of the updates in the field of lung cancer. Now, I know that on almost every other day we would have some webinar or the other, and a majority of all our webinars are going to be on lung cancer itself. But that just reflects two things. One is the magnitude of the problem. Lung cancer is still the commonest cause of death among men in India. That's one. The second is that the number of updates the number of new data, the number of information which is coming in the field of lung cancer, it is practice changing almost on a week-to-week basis. So it is in our own best interest to discuss these updates, try and come to a sort of a consensus if possible, and implement them in our day-to-day practice. To start off the show today, I would like to invite Dr. Nidhi Tandon. She is the consultant medical oncologist at Narayana Health City. Over to you, Dr. Nidhi.
Thank you very much, Dr. Aditya. And as you rightly said, we would be going to start our discussion with a topic which has literally changed the practice of lung cancer all over the world. Can you please share my slides? Yeah. So thanks AstraZeneca and MedGenome for helping me with the slides. I would be discussing today about molecular biomarkers in lung cancer. Next slide, please. According to GloboCan 2020 data, about 73,000 cases of lung cancers are reported in India, which constitutes about 5% of cancers. As is seen in the worldwide data, 85% of these are non-small cell, while 15% are small cell. Among the non-small cell, largely it is adeno, squamous, and large cell, but there are other rarer types of cancers like adenosquamous and sarcomatoid. Till now, we have been using chemotherapy with some results, but it was not able to prolong the survival of these patients beyond 14 to 18 months. But recently, we have opened the gates of personalized targeted therapy based on certain genomic alteration, which have literally resulted with not only a very good quality of life, with an intake of an oral medicine at the comfort of their house, but has also prolonged the survival to years. Next slide, please. So apart from the targeted therapy, we have now the option of immune checkpoint inhibitors, and it is just adding to the armamentarium of lung cancer treatment, which has already expanded with the variety of mutations. According to a pooled analysis of patients, overall survival has significantly improved in patients who receive targeted therapy as compared to those who do not receive targeted therapy by over 7 months. But more importantly, if you have certain alterations like EGFR and you use third generation or beyond TKIs like osimertinib, we have data that the patients have disease control even beyond 3 years, which was unheard of till now. Next slide, please. So this is the slide you have been seeing in a variety of presentations, and it just shows what all genetic alteration can act as oncogenic drivers in non-small cell lung cancer. The most common is, of course, EGFR, which is seen in almost 30% of the patient. Then is KRAS and BRAF. Now KRAS is also important because we also have a targeted therapy against KRAS, which G12C, which was not there till recently. But there are other mutations like ALK, ROS, MET, RET, ERB2, FGFR, NTRK, which comprise between 1 to 5%, and if found in your patient can also have a targeted therapy available. Next slide, please. So this is how NCCN details the treatment of advanced and metastatic non-small cell lung cancer. So if it is adenocarcinoma, large cell carcinoma, or non-small cell lung cancer, which is not otherwise specified, then the testing of these mutations is a must. But even in squamous, the testing is highly recommended. So if the incidence is up to 30% in adenocarcinoma, it is up to 3% only in squamous, but that 3% becomes a significant number if the patient is old, debilitated, has comorbidities, which is often seen as in lung cancer patients, and is not willing to take chemotherapy. Next slide, please. So we have a variety of option, IHC, FISH, PCR, NGS, but all of us would agree that we now prefer doing a broad panel-based approach, including NGS. Now, NGS is again DNA-based and RNA-based, and RNA-based has an advantage of maximizing the detection of fusion events. So especially for non-smoker patient, RNA-based NGS should be performed in addition to DNA-based NGS, if not already, if the mutations are not already detected. Earlier, Sanger sequencing was used, but it is important that Sanger sequencing requires a great degree of tumor enrichment, and there must be at least 25 to 30% of the tumor after enrichment for making Sanger sequencing possible. The other technique which we are using commonly is PCR, but PCR is highly targeted, so it will only be useful when it is deployed for a specific alteration we are looking towards. Next slide, please. So right now, for EGFR, exon 19, 21, 20, and T790M, we have the option of PCR as Sanger or real-time and next generation sequencing. And of course, we are aware about the first, second, and third generation TKIs available against them. I'm sorry, I got disconnected. Am I audible now?
Yes, ma'am.
Yeah, sorry. Similarly, for ROS, initially it was IHC, but now we have FISH, and NGS, of course, is available. KRAS and BRAF again have can be detected using PCR and NGS. For KRAS, we have recently found a targeted therapy in form of sotorasib, and for BRAF, we have the option of using TKI, dabrafenib, and trametinib. Next slide, please. Next slide, please, Karima.
I already do, ma'am.
Okay, mine, it is not changed. Yes, thank you. Then we have other rarer mutation like MET, RET, NTRK, ERB2, for which NGS is the preferred modality. And we have found targeted therapies for those mutations. PDL1 is generally found ascertained on IHC. Different type of immunotherapy for different type of immunotherapy agents, different type of antibodies have been used for the IHC, and we will talk about it in further slides. Lastly, we have tumor mutational burden. Based on an NGS panel, we can find the total number of mutations, and it has also been found to be a surrogate marker for the use of immunotherapy. I think Garima, the slides are not visible. Hello? Hello?
Ma'am, maybe Gitika got disconnected. Ma'am, give me a just minute, ma'am.
Hello.
Hello?
Ma'am, my voice is audible?
Yes.
Sorry, my internet was lost.
No problem. Thanks. We'll go to the next slide, please. Next slide, please. Yes. So we discussed about what mutations we test
Now it's
commonly, and now we would be discussing about individual mutations. Yeah, I got it. Thanks, Gitika. The most among EGFR, the most common mutations include exon 19 deletion and exon 21 point mutations, which are EGFR activating mutations against which all the TKIs will act. Of course, the third and fourth generation would have a better penetration to the brain and would have a longer overall survival. Exon 20 insertion mutations or exon 20 duplication mutations have primary resistance mechanism against the TKIs. If we use a targeted PCR-based approach, then we may under-detect exon 20 insertion, and here NGS becomes a preferred modality. T790M is a mutation which is usually seen as a secondary resistance mechanism after the use of prior TKI, and in such situation, we can use osimertinib, which will act against that. However, if T790M is detected in absence of prior EGFR TKI therapy, then genetic counseling and possible germline mutation testing is required. Next slide, please. FGFR 1, 2, 3 mutations are also reported infrequently in NSCLC, and till recently it was thought that it was only seen on patients progressing after EGFR TKI therapy in EGFR mutant lung cancer patients. But recently it has been found that it has in 23% it also coexist along with EGFR mutation, and in patients who have concurrent EGFR and FGFR mutation, 41% there were EGFR resistant mutations also, and therefore this could also be an acquired mechanism of EGFR TKI resistance. Hence, if we are planning to use a EGFR TKI, we should be testing for both, and maybe a combination of EGFR TKI and FGFR TKI will represent a promising strategy. Next slide, please. ALK mutations in NSCLC there are multiple mutations which are seen. Initially, we used to use FISH, then came IHC, and now we have NGS. G1202R is the most common secondary resistance in ALK mutant in patient post-treatment with second generation ALK TK inhibitors. Lorlatinib is a reversible third generation ALK and ROS inhibitor which can overcome multiple such resistant mutation. Next slide, please. RET alterations occur in 1 to 2% of non-small cell lung cancer. The most common rearrangement is between intron 11 of RET and intron 15 of KIF5B gene. Selpercatinib and pralsetinib are both TKIs which act against RET mutations. Next slide, please. MET mutations also there are a variety of MET mutation which may lead to MET amplification, MET overexpression, and HEF overexpression. But the most common mutation which we are concerned about is MET exon 14 skipping mutation, which can be detected by NGS or hotspot testing. And now we have therapies like capmatinib available, which can act against these mutations. MET exon 14 mutation, unlike other mutations like EGFR, ALK, and ROS, are seen both in smokers as well as non-smoker. and it has a slightly higher predilection for elderly patient as compared to young patients for EGFR ALK-ROS. Also, it has been found that sarcomatoid type of lung cancer have a high incidence of MET exon 14 mutation. So if we are not doing a complete NGS panel for lung cancer and we are doing a targeted PCR testing, then those type of histology, that type of histology should specifically target us to test for MET exon 14 skipping mutation. Next slide, please. MET amplification can be de novo, and it can be an acquired resistance after EGFR TKI therapy. EGFR inhibitor resistance attributed to MET amplification is reported after up to 20% after first generation TKI and up to 25% after third generation TKI. Next slide, please. ROS1 rearrangement again occurs in 1 to 2%. Crizotinib is the preferred agent, but now we have ceritinib, lorlatinib, entrectinib, and other therapies which are coming into use. Next slide, please. KRAS is one of the most common oncogenic driver in lung adenocarcinoma, which is seen in up to 40% of patients, and 13% of the patients among these harbor KRAS G12C mutation. Sotorasib is used to treat NSCLC patients which are having this mutation. Unlike EGFR, ALK, and ROS, most of the patients who have KRAS are smokers, and only 5% of KRAS mutation occur in light or non-smokers. Also, unlike EGFR, ALK-ROS, which are primarily predictive biomarker, KRAS is a prognostic biomarker also, and patients with KRAS mutant NSCLC are found to have a shorter median overall survival and a lower 2-year survival rate. Targeting KRAS downstream effector molecules like PIK3, mTOR, BRAF, MEK show promising prospects, but now, of course, we have the evidence to use sotorasib. Next slide, please. NTRK1, 2, and 3 gene encode for tropomyosin receptor TRK-A, B, and C respectively. And they have been found to occur in about 1 to 3% of patients of both adenocarcinoma and squamous cell carcinoma histology. Larotrectinib and entrectinib are the FDA approved agents against these. Next slide, please. PD-L1 testing is for the use of immunotherapy, and different type of immunotherapeutic agents have used different antibodies to test for PD-L1 IHC. Pembrolizumab uses 22C3 antibody clone, while atezolizumab uses SP142, nivolumab uses, and durvalumab uses SP263. NCCN has approved pembrolizumab, atezolizumab, and nivolumab as first-line therapy in metastatic lung cancer, while durvalumab has been approved in stage 3 after definitive CTRT as maintenance therapy. Next slide, please. Tumor mutational burden is an measure of the total number of somatic mutation, and it has been found that in among all the solid tumors, high level of tumor mutation burden correlates with high neoantigen level and therefore are more susceptible to immunotherapy. Tumor mutation burden levels are high in patients who are smokers as compared to those who are non-smokers, and immunotherapy could be of use in such patients. Next slide, please. Last but not the least is liquid biopsy. All of us realize that tissue is always an issue in lung cancer because one, the biopsy is more invasive. There is a risk of pneumothorax and other complications while doing a biopsy from the lung lesion. The biopsy from mediastinal lymph nodes is a skill. Getting a biopsy from there is a skill on its own. And more importantly, a lot of these patients are elderly or have other comorbidities like COPD or ischemic heart disease, which makes biopsy difficult. And hence, when we have to get such a lot of tests done to decide our therapy, then we always lack tissue, and liquid biopsy in form of the use of circulating tumor DNA cells, which are the cell-free DNA fragments that are released into bloodstream, is a possible modality to be used to get an answer to our question. Next slide, please. It has been recommended for molecular testing, but it is not a replacement for diagnostic tissue biopsy. It was only recommended in patients where we have an insufficient tumor tissue specimen or where the tissue specimen is not obtainable. And it is important to remember that we have almost a 30% false negative rate by using a liquid biopsy. Next slide, please. So if we perform a liquid biopsy, we see a targetable resistance mutation present or not. If a targetable mutation, resistance mutation like T790M is present, then we can treat with the standard of care therapy like osimertinib. But if that is absent, then the answer is actually a rebiopsy. Next slide, please. The last is parallel versus sequential testing. So parallel, in either approach, we do the ALK, ROS and PDL1 testing by IHC first. And then in the parallel approach, we use both the DNA NGS and the RNA NGS simultaneously, while in the sequential approach, we use the DNA NGS first, followed by RNA NGS. Next slide, please. Parallel approach was shown to be feasible on small tissue samples, including cytology tests, and it can drastically reduce the cost and complexity of molecular workup. But for never smokers, a parallel approach is definitely recommended. Next slide, please. So the takeaway messages from the talk today would be: number one, the analysis for the molecular testing should be sent as soon as possible, possibly by a broad-based assay like NGS. And the advantages of this are that we detect the potential for targeted treatment early, with reducing the wait time as well as the anxiety of the patient. But the problem lies that we need to educate the providers in departments of pulmonology and thoracic surgery and other colleagues, apart from only the medical oncology team. Second, there is a possibility of use of liquid biopsy, though it is not a replacement for tissue biopsy, but it could be useful when the patient is too sick to get a biopsy or the tissue is limited and we do not have much options available. And third, a pathology important message is that a pathologist may direct a reflex testing once the diagnosis is confirmed, because it increases the number of patients tested and it reduces the time to start treatment, but it may incur increased cost. Next slide, please. Thank you.
Thanks, Dr. Nidhi, for such a important, such a lucid talk on the role of NGS in management of lung cancer. In the interest of time, let's move on. So, sort of trying to give a continuum from Dr. Nidhi's talk to our next speaker. Very recently, let me share that the last case of EGFR positive lung cancer that we diagnosed was by the liquid biopsy technique only. Unfortunately, for some strange reason, we did not have enough tissue. And when we sent for the NGS testing, and only recently did I learn that there is something called as a parallel sequencing and something called as a sequential testing. Even the problem is when there is tissue less, and when there somebody wants to do the DNA and the RNA together, there is a possibility that the DNA might work, but the RNA might the RNA might work, but the DNA might fail. And with the RNA, we can make out other ones, but we cannot make out EGFR testing if the DNA thing fails. So we tried on the tissue for nearly a couple of weeks, and finally the tissue failed. We sent liquid biopsy within 5 days. Voila, we had the report, and now the patient has been started on osimertinib. So moving from the testing to the first line management, it's my pleasure to invite Dr. Mohammad Nasir, consultant medical oncologist at SCG Hospitals, Bengaluru. Over to you, Dr. Mohammad Nasir.
Thank you, Dr. Aditya. Can you hear me?
Loud and clear, yes.
Yeah. Kirti, can you share the slides for me?
Sure, sir. Gitika, kindly help.
Yeah. I really thank the organizers for giving me this opportunity to talk about recent advances in the treatment of EGFR mutated non-small cell lung cancer. The discussion here would be to initially talk about the burden and treatment strategies in non-small cell lung cancer according to the guidelines, and understand what are the emerging first-line treatment landscapes of targeted therapy in EGFR mutation for positive non-small cell lung cancer, and what is the safety and efficacy data with respect to the different targeted therapies which we have for this set of patients, and finally discuss the role of osimertinib in the first-line treatment of metastatic non-small cell lung cancer. Yeah, can you have the next slide? So coming to the burden and treatment strategies of non-small cell lung cancer, we know it is one of the common diagnoses in clinical practice. And as per the Globocon 2020 data, lung cancer is the second most commonly diagnosed cancer, and one in incidence is 1 in every 10 cancers, and mortality is 1 in every 5. So among the some of the important statistics are given on the right hand side. So 80 to 85% of the cases are non-small cell lung cancers, and we know that the median overall survival for the metastatic stage 4 disease is approximately 4 to 5 months with just supportive care without any targeted therapy. And the 5-year relative survival rate for metastatic non-small cell lung cancer is approximately 6% when it comes to the historic cytotoxic chemotherapy regimens. So, which is definitely not the number when we are treating with target therapies. And patients with metastatic non-small cell lung cancer with targeted immunotherapies, like we have a very good 5-year survival rate, which is from 15 to almost 50%. So next slide. So overview about the EGFR mutation positive cases. Like we know, the EGFR mutation rate is approximately 40% and 20% in Asians and non-Asian population. Whereas when it comes to Indian setting, the patients in India with non-small cell lung cancer have an approximately 20 to 23%, like approximately like 1 in every 4 non-small cell lung cancer patient can be EGFR mutation positive. And how does it work? What is the reason? Why is it called a driver mutation? Because these mutations are located in the tyrosine kinase domain, and the increased activity of the tyrosine kinase activity of EGFR leading to continued cell proliferation and development of cancer. You can see in the pie chart, most of the mutations are numbered from exon 12 to exon 12, and then 18 to 21. So the most common is exon the 52.63%, which is in exon 19. Rest are the other common mutations which are seen. So deletion mutation exon 19 and exon 21 LR858 are the most common mutations seen with respect to when it comes to EGFR mutation testing. Next slide. So there are different generations of tyrosine kinase inhibitors acting against this EGFR site. So these are categorized in first, second, and third generation. The first generation TKIs are erlotinib and geftinib. Second generation are afatinib and dacomatinib. Third generation is osimertinib. So how do they differ? They differ with respect to their activity range as well as the site of inhibition. First generation, they have that specific EGFR inhibition, but they are reversible both to wild type as well as mutant EGFR, but they're inactive against TM790 mutation, which is one of the most common resistant mutation. So that is one of the disadvantage of this generation of TKIs. Second generation TKIs, they also, other than EGFR, they block ERB2 and ERB4. So they have additional activity. So this broader activity tries to overcome some of the EGFR mutation, tyrosine kinase mutations. And the third generation, which are EGFR mutation specific inhibitors, they're irreversible, covalently binding to the mutant EGFR, and they have a very high specificity for TM790 mutations, and they spare the EGFR wild type. So the side effects are also relatively less in that. So third generation are more specific for TM790. First generation doesn't have this activity. Can we have the next slide? So there are this is the slide which tells you about how the progression-free survival and the overall survival with respect to different generation of TKS has come into being in the timeline. So it started with IPAS in geftinib, testing with systemic chemotherapy. Most of the first generation TKS have been tested with systemic chemotherapy as a standard of care. Geftinib in the IPAS trial had a PFS of 9.5 with an overall survival of 21.6 months. Similarly, in the NEJ002 trial, almost similar numbers with a high overall survival, 27.7 months. Whereas for UTAC in erlotinib, this trial had a overall survival of 19.3 months. Whereas in the ENSURE trial, it had a higher overall survival of 26.3. So most of them had a very good PFS, but the overall survival was not very much significant. Then came the second generation TKIs, where these two trials, Lux Lung 7 and Archer trial, these two trials were tested TKI versus TKI head-on, afatinib versus geftinib, and dacomatinib versus geftinib. So they had a very good PFS, definitely more than the first generation. Within the Lux Lung trial, afatinib had a PFS of 11 months and an overall survival of 27.9. Whereas in dacomatinib, it further had a better PFS of 14.7 and overall survival of 34.1. Then came the next generation TKI, osimertinib. In the FLORA trial, what they found out that it had a very good PFS, almost 18.9 months, double than that of first generation TKI, and the overall survival is also significant with a survival of 38.6 months, more than almost more than 3 years. Next slide. So in the subsequent slides, we'll be discussing about the first-line management in EGFR mutation and which is the best option among these TKs which are available. Yeah. Can we have the next slide? So these are some of the highlights where we will be talking about how we choose the first-line EGFR TK and what is the treatment goals. What are the treatment goals we target? So a typical EGFR TK should have all these requirements, like it should have a longer progression-free survival, it should give a higher objective response rate, it should also have a better overall survival. And we know that EGFR mutant patients have a propensity to develop CNS metastasis subsequently as the disease progresses. So that TK also should give us a better CNS protection. That is also one of the important requisites. And definitely the safety profile and tolerability also is an important aspect desired, and it should also improve the quality of life. And subsequently, when the patient takes a treatment, that has to be prolonged, like prolonged time to first subsequent therapy. All these are the required prerequisites when we think of choosing a EGFR TKI. Next slide. So some of the important TKIs we'll be discussing here. If you see the three trials in the second generation and the third generation TKIs, the Lux-Lung trial where there was comparison of afatinib versus geftinib, the PFS was almost the same. Afatinib of 11 months, geftinib 10.9 months. But a hazard ratio of 0.17 and a p-value of 0.01, which was significant. And in the Archer trial versus comparison of dacomatinib versus geftinib, the PFS, we can see the separation of PFS happening at 6 months. It's a relatively early separation compared to what separation we had seen in the previous trial, where the separation was almost at around 1 year. So this had, in less than 50% of the time, there was good separation of the curve, and the median PFS was 14.7 months. So it was an added advantage here. Subsequently, when we see the FLORA trial, in the osimertinib arm, you can see there is immediate separation. So this drug brings about very good effect and advantage since the beginning of the start of treatment. So the PFS here is 18.9 months with a comparison to the standard of care of 10.2 months. It's almost double the PFS advantage with a very good hazard ratio, 0.46, and a significant p-value. So concluding this, we see that osimertinib shows the highest median PFS and early separation of the PFS curve. And we know that early separation of the curve indicates a lower frequency for early resistance to the drug, and is one of the prerequisites for choosing the drug for first-line EGFR TKI. Next slide. And if you see the mutation subgroups in these trials, the two common mutations which were tested were exon 19 deletion and LR858 mutations, which are the common mutations seen in these patients. So in all the subgroups, there was a better response to the TKI. So in the afatinib, it had a better response of 12.7 months in exon 19. Dacomatinib had a response of almost 16.5 months, and osimertinib, you can see it is 21.4 months. So exon 19 mutations, they do well compared to LR858 mutations, which have a slightly lower PFS compared to that of exon 19 deletions. So the conclusion is that in osimertinib, it demonstrated the longest PFS when we take the mutation subtypes. Irrespective of the mutation subtypes, it has a higher PFS. Next slide. So when you come to the next aspect, the higher objective response rate. Next slide. In these trials, in the Lux-Lung trial, we see that the overall response rate for afatinib versus geftinib was 70% versus 56% with a significant p-value. And the duration of response was also 10.1 months. Whereas in the Archer trial, the oral response rate was almost the same, 75 versus 72. Yeah, that is one of the drawback of this trial, and with an insignificant p-value. But you see the FLORA trial, the overall response rate was 80% compared to standard TKIs in the trial which were used was 76. For the median duration of response, we can see it was 7.2 months, double that of standard care, almost double that of standard care. So it also had a highest overall response rate and the highest median duration of response. Next slide. When we talk about the improved overall survival, can we have the next slide? So in the Lux-Lung trial, we see that the afatinib had a overall survival of 27.9 months, but the p-value was 0.2 and the hazard ratio of 0.86. So it wasn't significant with respect to overall survival. When you see the Archer trial, we see the numbers dacomatinib versus geftinib, 34 versus 27. The hazard ratio also is 0.7 and the p-value of 0.01. But this overall survival analysis was actually done on an ad hoc analysis basis, as the overall response rate in the previous slide which we saw was not statistically significant. The statistical significance of overall survival was not attributed to usage of dacomatinib. So that is one of the reasons why overall survival was not very much significant in the Archer trial. Whereas in the FLORA trial, we see 38 months versus 31 months. So with a added advantage of 6 months, hazard ratio of 0.8 and p-value of 0.04, and a very good response, I mean, better response rate compared to standard of care TKI. It was a conclusion saying that osimertinib significantly improved the overall survival versus the comparator arm. Next slide. So overall survival, the explanation for overall survival in Archer trial in the Canadian consensus, where the new systemic treatment algorithm was adopted, where the hierarchical statistical testing order was first they tested PFS, then overall survival, overall response rate, and overall survival. So although this trial reported a numeric improvement in the overall survival, the overall response rate did not have a significant p-value. That is the reason why overall survival importance could not be attributed here. So that is one of the drawback of this trial, and it was not formally assessed, the overall survival. Next slide. Next slide, please. So another important aspect is, like I told you, the protection from development of CNS metastasis. So if you see the trials here, in the LUX-Lung trial, the patients with CNS metastasis were included, whereas in the Archer trial, CNS metastasis patients were excluded. That is also one of the drawback of this trial. And in the FLAURA trial, comparing osimertinib, approximately 19% of the patients were included. So if you see in afatinib versus gefitinib, there wasn't any significant improvement in the PFS, CNS PFS, whereas in the FLAURA trial, the PFS was 15 months versus 9.6 months with a significant p-value. So they concluded saying that osimertinib represents a clinically significant treatment option for patients with EGFR mutation, especially with brain metastasis. Next slide. So patients with CNS meta, and there are two separate the Kaplan-Meier curves you can see. On the left-hand side, patient with CNS metastasis. On the other side, it is without CNS metastasis. So both the patients had an early separation of the curve and early and higher PFS. For patients with CNS metastasis, it is 15.2 months, whereas without CNS metastasis, it was much better, 19.1 months. So it demonstrated a superior systemic PFS regardless of the CNS metastasis. So that is one of the important added advantage that irrespective of the CNS metastasis, we can choose osimertinib for the treatment of these set of patients. Next slide. So once again, in the Canadian consensus, it is preferred that EGFR TKI osimertinib is the one with which can be used for the patients with the brain metastasis or the leptomeningeal diseases. The recommendation is 2A, and the evidence is that almost half of the patients with metastatic EGFR mutated lung cancer develop brain mets during the course. And since osimertinib has a very compelling data with patients with CNS metastasis, so this is one of the most preferred drugs. Next slide. When it comes to the safety profile and the adverse events, we can see that the grade 3-4 grade 3 adverse events were more or less the same, but in dacomatinib it was 51%. Whereas grade 5 adverse events were more in dacomatinib, and osimertinib and afatinib they were not very significant. And most common grade 3 adverse events were diarrhea, rash, and fatigue for afatinib, whereas acne and diarrhea in case of dacomatinib. So less rashes in case of dacomatinib because it is a second generation, and in osimertinib diarrhea is a common side effect, whereas rashes are not seen. So this says that the second and third generation TKIs are better tolerable compared to that of first generation TKIs. So we can see that more than grade 3 adverse events with osimertinib were reported in 32% of the patients in the FLAURA trial, whereas it was 62 in the dacomatinib and almost similarly 31% in the LUX-Lung trial. So osimertinib is also a better tolerated drug when it comes to the grade 3 adverse events, more than grade 3 adverse events. Next slide. And another important aspect in clinical practice is the dose reductions, or do we have to go for treatment interruption? So in the afatinib trial, they found that 41.9% of the patients required frequent dose reduction, whereas dacomatinib also has a significant number of dose reduction. You can see in the green highlighted tab, Osimertinib just had 4% dose reductions. So it which indirectly tells us that it is a better tolerated drug with respect to adverse events. And treatment discontinuation also in the afatinib it was 6%, whereas dacomatinib and the osimertinib almost were similar with 10 and 13% respectively. But the frequency of dose reduction is significantly less in osimertinib. Okay, yeah, next slide. With respect to dose reductions, especially in the dacomatinib arm, it comes with a prescribing information that the first dose has to be 45 milligram per oral. And if there is any unacceptable toxicity, then one has to go for a dose reduction of 30 and 15. So in Archer trial, dacomatinib, the 66% had the dose reductions. The median time for the first dose reduction was 2.8 months. This usually says that with dose reductions and a less number of median time for the first dose reduction, it is relatively an intolerable drug with a 45 milligram per meter square, often requiring dose modification to 30 mg. Next slide. So then another important aspect is the quality of life. In the LUX-Lung trial and the FLORA trial, both parameters were assessed with respect to quality of life measurement. And it was found that improved quality of life was seen with respect to in both the TKs, but especially in osimertinib arm, had a better improved TK compared to other standard of KTKs. Next slide. And in the Archer trial, when they compared the different aspects of assessment in the quality of life, the overall quality of life improved significantly with geftinib than dacomatinib. Probably it is one of the reasons could be dose reductions and intolerability of the drug. Whereas in the FLORA trial, similarly, osimertinib was found to be one which had improved quality of life compared to other TKs. Next slide. And subsequently, how the patients do following the usage of the first TK. First, subsequent therapy received. In the osimertinib and the comparator arm, we see that still many patients are still receiving osimertinib. Almost 22 patients are receiving the osimertinib, whereas in the comparator TK, only 5 patients are receiving the standard of care TK. Subsequently, other TKs and cytotoxic chemotherapy drugs are commonly used in the first subsequent therapy which is being given following progression. Next slide. So these numbers are important here. Time to first and second subsequent therapy. TFST, the duration is almost 25 months for the first time to first subsequent therapy in osimertinib, whereas time to second subsequent therapy is almost 31.1 months. So these are the very good numbers, especially when it comes to time to first and second subsequent therapies. Next slide. In the coming slides, we'll see is the sequencing the right strategy for EGFR mutation non-small cell lung cancer patients? Like how do we sequence the patient and which is the best drug initially to start with? Next slide. So we see that definitely now the treatment of metastatic EGFR positive patients is now changed over from systemic chemotherapy to EGFR TKs. But all the EGFR TKs are not equal. So it depends on what drug we are choosing and how the data has arrived from. So in the LUX-Lung trial, which was afatinib versus geftinib, CNS patients were included. They had a significant median overall survival of 27.9 months, and adverse events were 31%, and quality of life was okay. Whereas in the Archer trial, comparing dacomatinib versus geftinib, the study did not include CNS disease patients, but they had a better median overall survival of 34.1 months and good overall response rate. But the safety profile was not very good because more adverse events and dose reductions were seen. So that also reduce the quality of life. Whereas all these drawbacks were covered by the third generation TKI osimertinib, where the patients with CNS metastasis also were included in that trial, which according to the date of which this came into being. So irrespective of the CNS metastasis, it did well and had a very good median overall survival. So, and overall response rate is also 80% and a very good PFS of almost 19 months. And safety profile is also better with very less dose reductions. And all these led to improved quality of life. So with respect to all the parameters, osimertinib stands ahead of the its comparator TKIs. Next slide. So, and what are the resistance pattern we usually see in EGFR patients, and what is the treatment for them? We know that the TM790 EGFR mutation is the most common driver
Oh, sir,
mutation.
sir, kindly conclude your talk, sir.
Yeah. And yeah, there are a couple of slides only. So for the resistant mutation, TM790 is the most commonly used, most commonly developed mutation, and EGFR TKI osimertinib is the drug of choice. Next slide. This slide says that like most of the patients subsequently do not get a chance of developing EGFR TKI osimertinib, so it is better to be used in the upfront setting. Next slide. Yeah, this also tells about the best option for TM790 mutation is EGFR mutation is osimertinib, and that is the drug, and the data is also which I have discussed before. Next slide. And this is the flow chart to which we see how the TKIs are usually preferred, especially with CNS and CNS with and without CNS metastasis. If it is EGFR exon 19 and LR85 mutation, osimertinib is the drug of choice. Next slide. And NCCN 2021 recommendations are also similar. Next slide. Next slide. Yeah, the NCCN 2021 recommendations also are like for upfront EGFR mutation patients. Osimertinib is the preferred drug of choice compared to other TKIs. And subsequently, when there is TM790 mutation, also if the other TKIs are used, osimertinib is the drug of choice. So adjuvant setting also there is a role of osimertinib, which is coming to be in stage 2B and 3A patients and stage 1B and 2A patients. Yeah, next slide. Yeah, can I have the next slide? Yeah, this is the final slide which says that like FLORA trial was the trial after which there was very good data for the usage of osimertinib. It not only improved the PFS but also overall survival. Very well tolerated drug, less adverse events, and since the patients usually don't get second line, third line TKIs as osimertinib, so it is better to use it in the first line. Yeah, can I have the next slide?
Thank you, Dr. Nasir, for such a wonderful presentation. And sorry, we had to cut you short because in the interest of time. So we'll take up questions for the panel discussion. And if you could please stay back for the panel discussion, I think we can discuss these issues a little more in detail. To introduce my next speaker, this is Dr. B.J. Srinivas, Senior Medical Oncologist practicing at HCG KR Road. He is going to be talking about the role of bevacizumab in the management of lung cancer. Over to you, Dr. B.J. Srinivas.
Yes, Dr. Aditya. So, shall I share my slides?
Yeah, please go ahead. Yes.
I think it's visible, no? My slides.
Yeah, visible. Please go ahead.
Good evening, everyone. So this is just the going back to the basics of the bevacizumab. in our study days. I think nothing new except addition of bevacizumab, the immunotherapy era. So we are revisiting this bevacizumab like a revision of bevacizumab trials. So that is what going to be there in the next 10 to 15 minutes. So I will not go into epidemiology of these things because already it is touched upon. So coming on to the evolution of treatment, I think most of we have seen since 2001 for including EGFR mutated patients, chemotherapy, and then with immunotherapy coming up in 2014 and 2015, and the different ALK inhibitors. So till 2017. So I will not go into details of this also. So regarding the VEGF inhibitors or VEGF molecule, so what is the rationale for using anti-VEGF inhibitors? Because the vascular endothelial growth factor is a key mediator of angiogenesis. Because it causes survival, increase in proliferation, migration, and increase in the angiogenesis or neoangiogenesis with increased VEGF levels, and thereby driving the tumor growth. So, so many trials, the basic experiments, basic trials have shown that the microvessel density is low. Then the prognostic value of those patients in the lung cancer is good compared to the microvessel density is high, and even when the VEGF levels are low, the prognostic value is good compared to when the VEGF levels are high. So so this is the basic experiment. I also had my thesis topic where I have done metastatic CA lung with VEGF levels, and most of the patients I could see that there is increase in the VEGF level in most of the patients with CA lung as well as the CA breast. Two sites I had, and both of them had a higher VEGF levels. So treatment algorithm without actionable biomarker. So we have, I need not to go into details of this. We have a squamous cell carcinoma, mainly the chemotherapy, and nowadays with the immunotherapy combination. And usually the non-squamous majority will be adenocarcinoma, where most of them we use the chemo plus immunotherapy, or sometimes with bevacizumab if there is atezolizumab combination. And if there is patients are not bevacizumab ineligible, so usually we use the chemo plus immunotherapy combination or chemo only. Based on the prior therapy, some of the patients, if they are stable disease, we usually continue the maintenance therapy with bevacizumab alone, or pemetrexed and bevacizumab, or pemetrexed alone, and sometimes with combination of pembrolizumab or gemcitabine as a switch maintenance therapy. So new first-line treatment paradigm for patients without actionable markers. So these are the previous 2006 clinical trials. These are the trials which we were studying in our training days. So this is the one of the trial ECOG 44599, where paclitaxel and carboplatin was combined, was compared with the paclitaxel carboplatin with bevacizumab. Especially in the treatment-naive advanced lung cancer patients. So these are both of the arms were well matched, and we could see there is a significant p-value with hazard ratio of 0.8, almost 20% of the patients benefiting with the addition of bevacizumab. And we all know the side effect of the bevacizumab addition, the hemorrhage, hypertension, proteinuria, which are the adverse events with most of the bevacizumab, which we all know in our clinical practice. So, so the summary of this trial is with pacli-carbo and addition of bevacizumab, there is a significant increase in the PFS value, though there's some PFS benefit is also 2.3 months OS benefit, and response rate also is increased compared to the chemo-only arm. So this is the one of the trial, AVILE trial study design, where they have compared the different doses of bevacizumab 7.5 mg and 15 mg per kg, and the chemotherapy arm being the cisplatin and gemcitabine, either of these experimental arms. So all the arms were well matched, 7.5 mg per kg and the 15 mg per kg. So we can see here patients with chemotherapy only arm has with addition of Avastin 7.5 mg per kg has done well with a good hazard ratio 0.75 with a significant p-value, and even patients with the 15 mg per kg also has done with a significant p-value and hazard ratio of 0.82. So this is the overall survival was not a significant improvement with the addition of this bevacizumab. So similarly, the safety profiles were similar to the previous trials with hemorrhage and hypertension, which are the commonest side effects which we have seen in our clinical practice. So this is the meta-analysis of different randomized clinical trials. Though there was no significant survival benefit, but we can see there is a marginal benefit which favors the bevacizumab in most of the trials. Especially the significant p-value we could see in ECOG 4599, where hazard ratio is 0.8, and AVILE 7.5 mg. There is a significant p-value, and most of other trials are just a borderline benefit. So as a maintenance therapy in NSCLC, we know there is a switch maintenance, continuous maintenance, and initially we used to give bevacizumab alone, or no bevacizumab with pemetrexed, and now with the immunotherapy, bevacizumab with immunotherapy or pemetrexed with immunotherapy. So these are the previous trials where they have tried the after combination chemotherapy with bevacizumab and cisplatin and pemetrexed. The patients were randomized into if there is a good response, stable disease, or partial response. Patient is continued with chemo plus bevacizumab as a maintenance, or the other arm bevacizumab alone, and continued till the progression of disease. So the both arms were well matched. So we can see that there is a PFS benefit with the addition of continue with the maintenance therapy after the patients were on PR or stable disease. OS from the induction therapy was not significant with p-value was not significant, though the hazard ratio is 0.88. And so we can see here the final results of efficacy. So PFS with the bevacizumab alone is not there, but with the bevacizumab and pemetrexed combination as a maintenance, there is a good p-value and good hazard ratio. And overall survival benefit is not there, but there is a significant response rate compared to the bevacizumab alone. And the median duration of response was 9.2 months, and median duration of disease control was also significant at the 7.8 months. So adverse reactions, adverse grade with bevacizumab and pemetrexed, we can see here hypertension, and the hypertension is the commonest one with bevacizumab, and pulmonary embolism is around 2.5. So I think the adverse events are highlighted. I mean, it's similar to the previous trials. So this is one more trial where they have done where they have done the maintenance with bevacizumab and pemetrexed, as well as the bevacizumab alone. But here the two comparator arms were there in the induction therapy itself, where bevacizumab is combined with either carboplatin pemetrexed or the carboplatin paclitaxel arm. And both of the PEM and carboplatin was continued with bevacizumab bevacizumab and pemetrexed as a continuous maintenance therapy till the progression of disease at 15 mg per kg of bevacizumab, whereas with Paclitaxel and carboplatin, it is only the bevacizumab at 15 mg per kg till progression of disease. So there is a significant p-value with the continuous maintenance with bevacizumab and carboplatin arm compared to the pemetrexed and bevacizumab arm. There is a significant p-value, and there is the survival benefit is not there in most of the trials. This trial also did not show overall survival, but PFS benefit was there. So I will not go into the details of the side effect because there is no new safety signals, and most of the patients had a hypertension as the commonest side effect. So this is the one of the trial maintenance bevacizumab and or pemetrexed. So here there were after the induction bevacizumab with carbo and paclitaxel, patients were randomized to 3 arms, either bevacizumab alone, pemetrexed alone, or combination of bevacizumab and pemetrexed combination. So most of the patients with bevacizumab and pemetrexed had a more survival benefit compared to the either pemetrexed alone or the bevacizumab alone. So this is patients. This is in patients with elderly patients, whether bevacizumab with the platinum combination 4 to 6 cycles followed by maintenance bevacizumab every 3 weeks until progression. So here the once again bevacizumab at 7.5 mg per kg and maintenance bevacizumab every three weeks until progression of the disease. So PFS was stratified by sex and PFS. So here also there is a clear benefit of addition of bevacizumab to the chemo combination in elderly patients also with significant with PFS of 6.8 months with addition of bevacizumab, and OS was not improved as in the previous trials. So this is the so one more addition was Atlas trial where they have tried addition of erlotinib to the bevacizumab maintenance therapy as a switch maintenance. We add erlotinib to the bevacizumab. So here they could see there is not much significant benefit with addition of erlotinib. This is unselected for EGFR mutated patients. Subpopulation, but subpopulation of EGFR mutated patients have a good PFS benefit in this study compared to the patients who are EGFR not mutated. So coming on to the EGFR exon 20 insertion. So we have EGFR 19 and 21 where we have a our conventional TKs work very well, but exon 20 insertion, which is uncommon mutation, where some of the drugs like uncommon mutation like afatinib, sometimes osimertinib, in some of the mutations, or the newer poziotinib is coming up. So whether the addition of chemotherapy and bevacizumab has done well in this EGFR exon mutation. So there are retrospective analysis, and it has shown that the chemotherapy and bevacizumab combination has really worked very well with significant PFS of 6 months compared to the 2.4 months in patients who are taking chemotherapy alone. So this is one of the real world data where exon 20 insertion, EGFR exon 20 insertion were tried with chemotherapy plus bevacizumab, chemotherapy alone, immunotherapy, and some of the TKs which we are using conventional TKs like geftinib, erlotinib, and they could see that the real world progression free survival is more in especially the chemotherapy, and even the overall survival is more real world overall survival is more in patients who are treated with chemotherapy compared to the TKI alone or immunotherapy alone. So even in the first line or the second line. So coming on to the two trials, last two trials with VEGF inhibitors and the immunotherapy. So rationale being the atezolizumab is an anti-PDLF antibody which has increased overall survival versus docetaxel in previously treated patients regardless of the PD-L1 level, and bevacizumab which is a VEGF inhibitor approved in combination with chemotherapy, and a combination of these two may provide synergistic anti-tumor effect. So that is the rationale for combining this anti-VEGF inhibitor with immunotherapy. So this is IM power 150 study design where there is a immunotherapy with chemo combination, and then immuno plus chemo plus bevacizumab, and the third arm being the chemo plus bevacizumab arm, and with continuation of the atezolizumab immunotherapy in the first arm. In the second arm, there is a continuation of chemo plus chemo plus VEGF inhibitor, and in the third arm, where there was no immunotherapy, the bevacizumab is continued till the progression of disease. And investigator assessed the PFS for intent to treat population and overall survival in the intent to treat population. So well matched, the groups were well matched in all the three arms. So there is a significant PFS benefit in intent to treat population with hazard with PFS of around 8.3 months, and with significant p-value, almost 40% of the patients getting benefit with the addition of atezolizumab and bevacizumab compared to the chemo and bevacizumab only. So even the overall survival in the intent to treat population is almost almost 20% of the patients have got benefit with this addition of atezolizumab and the bevacizumab to the paclitaxel arm, the chemotherapy arm. So, and most of, whether it is the PD-L1 high or PD-L1 low, most of the patients favors the immunotherapy plus bevacizumab. And some of the patients, almost around 10 to 14% of the patients were also included with EGFR and ALK mutation in this trial, where also they got benefit with the chemo, VEGF inhibitor plus the immunotherapy arm. And immune-related adverse events, which is not a new for us. Actually, we know the hypothyroidism, pneumonitis, hyperthyroidism, hepatitis. So at a different levels when the patients are treated with immunotherapy, and this is similar to the previous phase 2 studies in different immunotherapy trials. So conclusion being, it has a good PFS benefit, a good overall survival benefit, and this benefit was observed in patients with liver mets or EGFR genomic aberration across all PDF subgroups, regardless of TEF gene signature expression. And there is no increase in the side effect of immune-related adverse events when combined with the VEGF inhibitors. So the OS data is still not mature in combination with chemo and the bevacizumab. So this is the second trial, IM power 131, where they have used nab-paclitaxel. One of the arm has used nab-paclitaxel instead of and compared with carboplatin and paclitaxel. And here there is no bevacizumab in this trial. And there is an investigator associated PFS was the primary endpoint in this trial. And here also there is a clear-cut advantage of addition of the bevacizumab to carboplatin and paclitaxel arm with a 12-month PFS of around 24.7%. So though the overall data is not significant, so PFS benefit is there with this. So approved, it is molecular testing is essential in the management of advanced NSCLC, and so approved agents for EGFR all cross driver mutations are preferred as initial therapy. Combination chemo plus immunotherapy is a new successful first-line treatment strategy for these group of patients, and even patients with high PD-L1 expression. I think I will conclude my study, my talk by this.
Thank you, Dr. Srinivas, for such a nice, crisp presentation, especially, bringing back the a molecule which most of us had forgotten how to use in lung cancer at least. And hopefully I'll get to dwell on this on my panel next. Moving forward, we have a panel discussion today. The panel discussion is going to be a case-based panel discussion. I have a couple of cases, but depending upon the time, we will take it from there. I hope I am audible and my slides are visible. Organizers, my slides are visible full screen
No, sir.
now.
Not now, sir.
Wow. I mean, are my slides visible at all?
No, sir.
Yeah, 1 second. I'm doing that. Oh,
Yes, sir. Now it's visible.
okay, great.
Make the full screen.
Yeah. Okay, now I should be visible, correct? Okay, great.
Yes, sir.
So I have a very august panel with me. I have Wing Commander Dr. Rahul Sood, who is the HOD of Medical Oncology at Command Hospital. I have Dr. Rahul, welcome to this, please. I have Dr. Lepakshi, who is a consultant medical oncologist at Radon Cancer Center. Dr. Lepakshi, are you around?
Yes, Dr. Aditya.
Oh, fantastic. Okay, so we have Dr. Naveen, who's the consultant medical oncologist at Narayana Health City in Mysore. We have Dr. Rudresh, who's the professor of medical oncology at Kidwai Hospital, Bangalore. We have Dr. Nidhi Tandon, who our opening batsman for today evening, who's thankfully stayed back to guide us a little bit more on this whole topic. And we have Dr. Smita, again, professor of medical oncology at Kidwai Hospitals, Bangalore. So for the next 30 to 40 minutes, I let us go through a couple of cases on lung cancer. So I know this is very rare in our practice, but we here have a 67-year-old gentleman who comes with sort of a 3.5 centimeter tumor in the left lung. Not a very central tumor. The PET scan does not show any lymph nodes in the mediastinum. I know we can discuss about the role of EBUS in this setting, but I've got slightly different topics to discuss today. So we went ahead, did the surgery. The final histopathology basically came back as a tumor size 2.9 into 2.5 centimeters. Two lymph nodes were positive. So the final stage here was PT2 PN1 stage. Okay, so here let us start off the evening's discussion with Dr. Rahul Sudhir. Dr. Rahul, do you check for molecular markers in early lung cancer? And if you do you check for specific markers or the multi-gene panel?
Yeah, so for the early lung cancer panel, maybe about 6 months back, we were doing nothing. We were just holding on to what was being done previously. But we know now that there is data regarding the use of the tyrosine kinase inhibitors. So a specific marker that I will test in this will be definitely an EGFR I'll be testing. Coming to the multi-gene panel, I am not doing it as of now for early lung cancer.
Okay, and I assume early lung cancer means tissue would not be an issue. Would you do this on a pre-surgical specimen? Let's assume for whatever reason we are trying to do neoadjuvant chemotherapy. And patient finally ends up surgery after the chemo. So would you want to do on a pre-surgical tissue, or would you wait for the post-surgical tissue?
So I think the pre-surgical tissue is a biopsy, I assume. So
right, yes.
If the biopsy is adequate pre-surgically, I think we can go ahead with that on the biopsy tissue. Otherwise, the other preference will definitely be the post-surgical or the histopath specimen, where the tissue is definitely going to be adequate.
Excellent. So let me try and bring in Dr. Lepakshi into the discussion over here. Dr. Lepakshi, have you ever felt the need to send for a liquid biopsy in early lung cancer, or what are your thoughts on this?
No, tissue is sufficient in early lung cancer because most of the times we will get sample post surgery only. Tissue is not a challenging here. So we can do on tissue blocks only.
And given that we have all the tissue in the world, would you check for ALK or PDL1 or any other marker here?
No, only EGFR right now.
So let me try and bring in Dr. Nidhi here, and given that Dr. Nidhi, you spoke on the role of NGS here. Is there any time or any specific indication wherein you would want to do a NGS panel testing in early lung cancer? Dr. Nidhi, are you around? Okay, can I ask Dr. Naveen to take this question? Dr. Naveen?
Yeah, hello. Very rare to get such patients, this one early stage in our this one setting. Because most of the NGS are right now covered under some patient benefit, and it means I just see if the patient can benefit with such coupons and all, and such cases I get both this PDL1 and NGS for them.
So Dr. Rudresh, let me try and bring you in here, Dr. Rudresh. Dr. Rudresh, are you around?
No, sir.
Okay. Dr. Smita is around. Dr. Smita?
Yes, Dr. Aditya.
Hi, Smita. Smita, so what are your thoughts on IMpower 010 and ASCO also, I think couple of months back came out with a clinical practice guideline recommendation about the adjuvant use of atezolizumab. Could you throw some light in that aspect, please?
I mean, it has shown a benefit of DFS benefit, the adjuvant in the early lung cancer. But I think to get it, still for our patients, specifically to get into the practice will be a challenge because of mainly the cost implications, adjuvant.
So just for a moment, if we can sort of leave the cost aside, let's assume you get
the DFS advantage, I think, is quite a good, significant DFS advantage as per the IMpower and the ASCO guidelines, what I remember reading. So it is definitely promising, the data. So I will be, pretty tempted to use it.
Dr. Rahul, your thoughts on this? I mean, let's assume for argument's sake that you're going to be treating Ambani or Adani tomorrow morning. Would you confidently recommend atezolizumab in an adjuvant setting?
No, I think not yet, because irrespective of the cost, now the data still is not mature. I still feel it is a work in progress. Yes. Like Dr. Smita mentioned, the DFS is promising, but we've seen with IOs, suddenly they come, suddenly they get withdrawn. So I won't say it is right now the standard of treatment right now. I think we should stick to the old school as of today, irrespective of whoever is the patient.
I think that's a very wise statement which has come from Dr. Rahul. See, with IOs, they come one day and then for God knows what reason the trial data sort of matures, and whatever was there in the DFS, that does not end up translating into the OS, and suddenly it gets withdrawn from the market. We have seen that happening in breast cancer. So when it comes to the use of IO, especially in the adjuvant or a neoadjuvant setting, we should always take that with a pinch of salt. But having said that, the hazard for DFS in IMpower 010 was a very, very impressive 0.66. Now, with time, we do expect this to translate into an overall survival benefit, and I still do believe that when we talk about an adjuvant setting or a curative intent of treatment, we should keep a very hard gold standard of an overall survival rather than try and move the goalpost by taking other endpoints. So Dr. Lepakshi, any reason why you would test ALK or any other marker in early lung cancer, or have you ever tested? What are your experiences in this scenario?
Honestly, Dr. Adit, before 6 months, we never used to test even EGFR also. But recently, with ADARA data, only we are doing EGFR testing only. So we don't have much data on ALK inhibitors. as an adjuvant.
Excellent. Dr. Naveen, any thoughts on this from your side? Naveen?
Sorry. I was
Yeah.
in mute. Yeah.
Yeah,
but,
sure.
yeah, definitely EGFR and the patient can afford some PD-L1 is also a good option, I think.
Excellent. So definitely we check for EGFR. We may or may not check for PD-L1 in this setting. So moving on to my next slide, adjuvant chemotherapy. So I mean, this is a real world scenario. So when most of the times patients who undergo surgery for lung cancer, at least upfront surgery for lung cancer, if it's just a lobectomy, that's fine. But some of them do end up undergoing pneumonectomy and their PS might drop. Would you under any circumstance, Dr. Rahul, consider dumping adjuvant chemo and just going with adjuvant osimertinib if your EGFR comes as L858R mutation positive?
So it is encouraging and tempting, but we've seen the data with L858R and the other TKIs. If it was exon 19, I would have no hesitations to give osimertinib to such a patient. But we've seen that L858R doesn't do well with even osimertinib or the decometinib. I, in this patient, would be tempted to give chemotherapy with osimertinib.
Okay, so Dr. Lepakshi, I think let's take it forward from what Dr. Rahul had told us. Let's assume that this is a exon 19 mutant patient. We know the response is fantastic to osimertinib. Would you be tempted to just say, okay, there is no point in chemotherapy? The whole LACE meta-analysis just showed a benefit of about 5% with adjuvant chemo. Am I justified in dumping adjuvant chemo if it is exon 19 and just go ahead with adjuvant osimertinib? Dr. Lepakshi.
Dr. Rajesh, still this adjuvant EGFR TKI data is still immature. OS also not sure because we are having earlier studies with Radiant and other adjuvant CTONG. So there also DFS benefit was there, not OS. So we have to wait, I think, just going into adjuvant EGFR TKI. So we are missing the like chemotherapy. That is the very important treatment aspect in the lung cancer as adjuvant therapy. So I won't consider jump into EGFR TKI without considering adjuvant chemotherapy.
Dr. Smita, this brings us to a very important point. How would you see? I know we cannot generalize things. Are you convinced with the ADAURA data, or would you still want to go ahead and look for the overall survival benefit?
See, definitely for us in the adjuvant setting, overall survival is a very important point, as just now rightly you said earlier also. So the ADAURA trial data is pretty impressive with the DFS. The OS also, I mean, we hope that we get this thing. But at the present moment, I will consider adjuvant therapy and only then probably EGFR mutation positive give the osimertinib benefit. So ADAURA trial data DFS wise is good, but I will still want the OS advantage.
So, Dr. Smita, you're telling, are you telling me that we have given the adjuvant chemotherapy and this patient has L858R mutation? Would you still recommend osimertinib, or would you tell, hang on, let OS come, let some more data come, and then I'll use?
No, I will definitely give the option to the patient, and I think I will use L858R, should use.
Dr. Naveen, any disagreement, any changes on this?
Yeah, the trial included both exon 19 and this one, L858R, this one mutation also. So I would definitely use it with HR of 0.17. Definitely I'll go for that.
Absolutely. I mean, that is very rightly put, a hazard of 0.17 becomes extremely hard to ignore for anyone, especially in a disease like lung cancer, wherein if the disease does come back, the patient's PS just drops exponentially. It is very hard to ignore. DCGI has also approved. We can see that NCCN has also approved the osimertinib in adjuvant setting. It has approved in stage 1B, 2A, 2B, 3A, and 3B, 3A for that this thing. In my own personal practice, I've had one patient whom I've just started. I think couple of months back, I started them on adjuvant osimertinib. Let us see how they end up doing. Under any scenario, Dr. Rahul, would you consider neoadjuvant chemotherapy in early non-small cell lung cancer?
New adjuvant therapy in early
NSCLC? Operable non-small cell lung cancer. I wouldn't say, let's say, forget 3A. I know 3A, it is a borderline discussion up until stage 2B.
2B, only when our surgeons plead, that is the only indication. And our radiation oncologist puts their foot back. Otherwise, that is the only indication I have seen in the stage that you have told me.
I completely agree with you. Anybody else has a differing opinion? Dr. Lepakshi, have you ever used neoadjuvant chemo in stage 2A or 2B non-small cell lung cancer?
No, Dr. I have never used.
So I think, another important point to sort of bring out over here is that management of lung cancer is always a multidisciplinary way modality. We need to get our surgeons and our radiation oncology colleagues on board, and at any point of time, especially in a scenario like if both of them do put their hands up, only then we come in. Otherwise, this if something can be resected, we have to go ahead with resection in this. So let's move on to a metastatic setting. We'll discuss a 54-year-old gentleman, former smoker, about 20 pack years of smoking, comes to us with a large left lobe pulmonary mass and right adrenal gland metastasis. There is no disease anywhere else. Biopsy has been done. Biopsy is adenocarcinoma. We have a stage 4 non-small cell lung cancer diagnosis over here. So before I jump into other things, Dr. Rahul, let's assume tissue is an issue. How comfortable are you in using liquid biopsy as a upfront molecular testing, number one? And if something comes positive, let's assume that liquid biopsy picks up a RET mutation or maybe a ROS1 mutation, are you comfortable in using the targeted therapy over there?
So I think we all learned that if the tissue is not available, I know the tissue is the paramount thing, but if the tissue is not available, the liquid biopsy is the way to go forward for such a patient, because the concordance rate between the liquid as well as the solid biopsy is pretty decent, I think. And if we pick up a mutation in the liquid biopsy in the absence of a solid tissue biopsy, we should honor it, and I think we should target it with the same.
Dr. Naveen, in your practice, are you doing the sequential or the reflex PCR based testing approach, or are you straight away going ahead with liquid biopsy with NGS panels here?
We are doing right now. Last 6 months, we have shifted to NGS panel, and getting a tissue for our patients is not an issue in our setting, and especially when the patient has done FNAC outside and has come here and he is not willing for a rebiopsy. There, we usually go for liquid biopsy sometimes.
I think we have Dr. Rudresh with us. Rudresh, are you around?
Yeah. Tell me.
Thanks, Dr. Rudresh, for joining in. So, first firing to you over here. Do you do liquid NGS panel testing in your practice? And if you do, what is the average turnaround time that you have? And how often do patients complain about the turnaround times?
Usually, liquid biopsy, very few. In our institute, what we are most of the time it is the tissue biopsy only. In whatever the patient we sent, the turnaround time around almost 2 weeks to 3 weeks. Now
So-
we
so-
are actually starting in-house, but not as standardized. So once that comes, then it may change.
So, Dr. Rudresh, let me put a scenario over here. How comfortable are you in let's say waiting for a ECOG PS1 patient? We are asking them to wait for maybe a couple of weeks till your tissue NGS panel comes back.
If patient is asymptomatic and performance status is good, definitely I will wait for the molecular test report, because the treatment management entirely differs. For example, if patient is having say EGFR ALK mutation positive, then there is no role of any immunotherapy.
Fantastic. I think, at least across the board, most on medical oncologists have a consensus now in, waiting till we get some sort of a diagnosis, in waiting till we get some sort of a molecular panel reports, unless the patient is very symptomatic. So, I mean, this slide, the questions over here is to all my panelists. Let me start with Dr. Smitha. Dr. Smitha, what would be your treatment of choice for this patient with EGFR mutant L858R mutation? You have the options on the screen over here. Would you use gefitinib, erlotinib? Would you use afatinib, dacomitinib, or osimertinib first line? Gefitinib chemo and or Erlo Bev, and the caveat here is that no matter what answer you pick, dinner will have to be paid for by yourself.
I will go with the first. I mean, the option, since L858R mutation is there, osimertinib, and I think with the relay data, even your erlotinib and bevacizumab also had a very promising data favoring for the EGFR mutation positive. But since L858R mutation, my first option would go osimertinib. And then any of the other things are all options.
So fantastic, Smita. Good. Let me discuss the point that you brought up over here, the relay data. So relay looked at a combination of erlotinib with ramucirumab, and the relay actually, I know it's not fair for us to tease things out. Flora did not have a pre-specified endpoint of a pre-specified differentiation between exon 19 and exon 21, but in the relay, the PFS which was seen with ramucirumab was probably higher than the PFS which osimertinib gave in the Flora study over here. Dr. Rahul, how much of a significance do you attach to this kind of cherry picking of data?
So we know, I think the L858R is a different subset of disease amongst the EGFR. So our tyrosine kinase inhibitors, which may be the Flora trial or the Archers trial, or the even the Lux Lung trial, they all showed that the survival vis-a-vis the exon 19 was literally half in this subset. However, the only trial which has shown a great benefit is the Relay trial, where the erlotinib ramucirumab was used, and this was this was the place where I think a survival benefit of 19 to 20 months was there, vis-a-vis the Flora trial, which had only 14 months. So if we go by this trial, then the L858R should be treated with a combination of anti-VEGF with the tyrosine kinase inhibitor.
Thank you. Because if you had not picked this option, I would have picked this option. Dr. Naveen, your thoughts on this, please.
Yeah, I agree with what Sarah said, but I have not used any patients on erlotinib with ramucirumab or such combination. Most of my patients end up with this gefitinib itself.
So, Naveen, so you are comfortable with interpreting data in this manner, that if it is exon 21, I pick a different protocol versus exon 19. So you are comfortable with that, Naveen, right?
Yeah, this one off late has started doing that, and also for very rare mutations also, I prefer afatinib in such cases also.
Okay, fantastic. Dr. Lepakshi, this is an important point which we need to spend some time on. What are your thoughts on this L858R osimertinib versus ramucirumab?
So I also completely agree with Rahul sir's opinion. Exon 21 patients won't do well, and I have not used erlotinib with ramucirumab, but erlo with bevacizumab I have used in many of our patients. So they are doing better compared to only TK. But the data on relay, I don't know OS is significant or not. The erlotinib and ramucirumab. So only PFS benefit, but still I consider osimertinib in this case, patients with L858R mutation.
Okay, so Dr. Rudresh, you agree with this? You have any thoughts on this, Dr. Rudresh?
Sir, I think he's driving. No, sir, he's left.
Okay. So, are there any takers at all for first line use of dacometinib, or I personally never used dacometinib, so I have no no idea to talk on this. Smita, have you used dacometinib? What are your thoughts on this? No, never. Rahulji, aap to you wouldn't have used at all. Lepakshi sir, have you used?
No, sir.
No. Naveen, you also wouldn't have used.
No.
Okay, so option number 2 is out. We don't pick option number 1 at all. So essentially, it's basically a toss up between osimertinib versus Arlo ramucirumab in first line. I do agree with Dr. Lepakshi to some extent that there have been times when patient could not afford anything else. We would use Arlo bevacizumab in first line and sort of try and save chemo to the next line. And one area where I have probably used a little more of bevacizumab is a patient with a brain metastasis. So if a patient has brain mets, in that scenario, would I and patient cannot afford osimertinib, then I might be tempted to use Arlo-bev, because Arlo-bev, especially in the brain metastasis, has shown some kind of a benefit over here. So this slide basically talks about all the various cross trial comparisons, and I think we have seen this data plenty of times, so I will not waste too much time on this. I think discussing Archer trial is basically irrelevant because most of us don't use this at all. Okay. Again, Flora was the first trial to show median overall survival of more than 3 years, and this is stage 4 lung cancer that we are talking about, and that's how far science has come. So that is, so every day we know osimertinib is making a great difference to all of our patients' lives. This question we sort of debated over the last 5 to 10 minutes. Yes, will the type of mutation that does influence our choice of EGFR TKI to a certain extent. So this is also there, not very significant. I think for EGFR exon 20 insertions or 20 mutations, J&J is bringing amivantamab, I think first quarter of next year. Mobocertinib is already available in compassionate basis, and positive trials are also going on. So hey, let me, before I go to the brain metastasis part of it, let me try and bring in another point or a slightly off-topic discussion. Let's assume that the patient is EGFR negative, and this is something which Dr. BJ Srinivas spoke about. Srinivas, are you around with us? Okay, I guess he has left. So, Dr. Rahul, under any scenario, let's assume that the patient is EGFR mutation negative and cannot afford first-line immunotherapy. How comfortable are you using Pem-Carbo-Bev, or what are your thoughts on use of bevacizumab in this setting?
Yeah, I think then that is the way to go forward in such a patient. The Pem-Carbo plus bevacizumab is our best bet in this patient. If the patient is symptomatic, though, we may need to give whole brain RT. If asymptomatic, then obviously this is the combination.
Smita, have you used Pem-Carbo-Bev, and how has your experience been with this?
Usually in our institute, our usage of the monoclonal Bev and all is less. So usually we go ahead with the Pem-Carbo with the whole brain RT. But I have used for a few patients, and yeah, wherever you have used it, they have done well in the private setup.
Dr. Naveen, your thoughts on this, please.
Yeah, I used for a few patients, 2 or 3 patients, I think this combination. Position Pem-Carbo with Bev, and all the 3 didn't do well in my case. So this in symptomatic patients, we usually go for whole brain RD followed by this one pembro with this one carboplatin.
So, so to sort of summarize, obviously, if we do have brain metastasis, the first the agent of choice would be osimertinib by a long distance. But if for whatever reason osimertinib is not affordable, not unreasonable to try some bevacizumab based combination over here. I would not discuss this data. I think everybody knows this data. Dr. Lepakshi, let's assume this patient had PDL1 60% or PDL1 70%. Would you favor starting IO in this patient?
So it's EGFR positive?
Yeah, EGFR positive. First line we are talking about.
No, so EGFR positive means the IO drugs won't take much. So I will consider osimertinib only in this case.
I think that is very rightly put. This slide talks about the role of immune checkpoint inhibitors in EGFR mutant stage 4 non-small cell lung cancers. Across all trials, we did come to realize that when there is a driver mutation, PDL1 is not a great biomarker to decide whether to use IOs, and better to stay away from them. The last couple of slides on safety profile of EGFR TKIs. Let me not go into this. Dr. Rahul, any very rare toxicity that you have seen with osimertinib?
No, I'll not say anything very rare, but yes, we come across rashes, acne, diarrheas, but nothing very rare. We do get elevation of transaminases in one of the patients we had. But then that was transient and it came down. Otherwise, the usual side effects.
Dr. Smita, how comfortable are you using bevacizumab, using osimertinib in a patient with cardiac dysfunction? Let's assume the EF is 35% or 40%. Would you continue to use it, or how would you monitor them?
I mean, as the class effect of the tyrosine kinase inhibitors, they can have a cardiotoxic effect. So therefore, we need to keep monitoring if the ejection fraction is less than 40%, definitely. But usually, I have not come across any patients in such situations where I've used osimertinib. I think if I have, we will use it and keep monitoring the ejection fraction, echo every 2 monthly or 3 monthly.
That's the right approach, Dr. Smith. I think the authors of Flora had a JCO publication about 6 months back. Along with that, there was also again another ASCO guidance on this with regards to use of osimertinib and is there any cardiac toxicity, and there was not much of a significant cardiac toxicity. So this is another thing that we need to remember, that although TKI as a class has some cardiac toxicity, osimertinib by itself may not have this kind of a toxicity, and it is not unreasonable to use it in patients with pre-existing cardiac dysfunction. Sequencing approach, I think this is the last question that I'm going to discuss today. Dr. Naveen, when would you consider a sequencing approach, and if yes, what would your sequence be?
Most of our patients with EGFR mutations, they usually start with using gefitinib or erlotinib under what you called this one schemes and all. Hello.
Yeah, correct. Go ahead, Dr. Naveen, please.
When the position progress and when we do the what you call mutation analysis, sometimes we change to osimertinib because they are affecting cases, but they come under BPL. Because that's like that thing. So such cases we usually do this one sequencing.
Okay, fantastic. Dr. Rahul, your thoughts on this, please.
I feel that sequencing is the right approach in lung cancer because I think if we sequence it properly, we can give years and PFS also to such individuals. But yes, the sequencing is only possible in situations like that. Like probably we start with the second generation TKI, then find out that the patient has progressed, developed an acquired mutation of T790M, give him a third generation TKIs, and in case he progresses on that, then check for that C797S mutation. Then either chemotherapy plus geftinib works. These are the ways we can, and I think sequencing plays a paramount role in lung cancer, even till date. But yes, exceptions are there where you have brain mets. Yes, then you go for a third generation TKI, or probably when you have no mutations whatsoever, then you go for chemotherapy. But preferably, I would like to go for sequencing in my patients.
Dr. Lepakshi, in any closing thoughts from your side?
No, it's same like Dr. Rahul sir. So I will consider first generation, then third generation EGFR TKI, then later IO plus chemo. So probably we can extend the survival with these 3 lines of therapy.
Dr. Smita, closing thoughts on from your side?
I mean, this is what we normally follow, the approach starting with first line and then going ahead. But I think with the as per the data from this trial, it showed that when you're using osimertinib in the first line, then the advantage of the patients are much better. And even the development of brain mets is lesser probably. So given an option, if it's a reimbursement patient or patient who does not, it's not a challenge, probably I will go ahead with the third generation upfront.
Fantastic. Dr. Naveen, anything to add from your side?
Nothing else. I think I concur with what she says.
Okay, great. So, Dr. Rahul, as always, the last word to you, closing thoughts.
I think everybody has spoken, and there's nothing more to sum up. And I think it was a wonderful panel from your end. Nothing more to add. And don't say last word from me, please.
Fair enough. I will not jinx it. I will not jinx it. So,
I am though privileged, and I am feeling high on this. But the stage is all yours, please.
So I will not jinx it. My apologies if I came across in that manner. But yeah, so osimertinib resulted in a significant improvement in PFS over standard of care. Only osimertinib demonstrated a statistically significant and meaningful improvement in CNS PFS also. This is the first EGFR TKI monotherapy to show a statistically significant overall survival benefit. Quite improved. Importantly, after 3 years, nearly a third of the patients in the osimertinib arm continued to remain on first-line treatment, and osimertinib has a favorable and consistent toxicity profile despite prolonged exposures. I thank you all for a patient listening, and I'm really thankful to everyone for staying back in spite of feeling so hungry. It's already 9 p.m. and I hand it back to the organizers. Thank you.
Thank you. Good night. Thank you.
Thank you. Thank you everyone for joining for a wonderful conference. We say good night to all. Good night, everyone.
Good night. Thank you.
Thank you.
Thank you. Good night.
Good night.